I still have one more meeting after you. And then I'm gonna drive to like 2 hours. So yeah.
That's great. And then I guess I'm trying to come out in November, and I hear you're gonna come with us.
Yeah. Yep. I am coming home next weekend, November 6th. So
Okay.
yeah. And then definitely, I know Mark was like, why aren't you coming with us?
I think
So
Gavin had a great time at the game.
he did. He did. I know. He really loves you guys. He's like, Mom, the best thing that happened to me since moving back is Mark and Jake. So
That's great to hear.
I know.
Hopefully he could take us on a nice campus tour to Indiana,
Yeah. Yeah.
because
So
Northwestern is not much to look around and see.
no, there's not. Yeah. Yeah. So it should be fun.
Okay, you
So
ready to start?
ready to start. Yeah.
All right, you want to introduce yourself, tell about your story, maybe where you went undergrad, graduate, PhD, and
Sure.
how you got into your counseling program and what you do in counseling, and I
Okay.
guess your specialty.
Yeah. And what class is this for? Just so I know the context and what is your assignment so I can stay on point.
All right. The official title is Counseling Methods in Practice. So
Okay.
I guess we're going to discuss just your basic stuff that you do, and
Yeah.
then we'll go into like the ethics portion of like
Okay.
how you keep files safe from people, don't share their information,
Yeah. All of that.
the
Okay.
confidentiality part, stuff like that.
Okay. Sounds
Whenever
good.
you want to start.
Okay, so I'm Dr. Susan McClahan. I have my PhD in clinical psychology. And first, I got a master's I got my undergraduate degree, a Bachelor of Arts in psychology from Duke University, and then a master's in developmental psychology from Columbia University in New York City, and then my PhD in clinical psychology from Northwestern Medical School.
And
So
did you
there were
always want to
two.
go into counseling?
Yeah, I mean, basically, since I was probably a teenager, I had decided I wanted to be in the field and be a therapist. And of course, at that time, it was certainly not nearly as mainstream as it is now for people to go to therapy. There was a lot more stigma. It was sort of like, whoa, why are you going into counseling? You'll never make any money. I heard that from everyone in my entire family, that this was more like, a very low paying kind of profession, and that I was going to be, people said, what are you doing? You're going to be in school till you're 32. And I said, well, I'm going to be 32 anyway. I might as well be 32 with my PhD. Um, but it was really, really hard in my 20s watching everyone, making money and kind of doing things. And I was really basically accumulating more and more
You said
debt.
you wanted to go into counseling when you were a teenager. Was there a specific moment in your life or a memory that stuck out or something particular
Yeah,
that
I
made
mean,
you
I
go that
think,
route?
yeah, I mean, certainly, I don't know if I knew this then, but I just figured it out later in life. I mean, my parents are Holocaust survivors, and there was a lot of trauma in our family history. And my brother is 8 years older than me, and he is on the spectrum, which we didn't know what that was then. So he was sort of somewhat of a disappointment, I guess, or brought more sadness to my parents. And I was sort of the person that a lot of the pressure kind of fell on, and also that was a caretaker. Just by definition, I was there to try to help my parents feel better and feel better about life. My brother was born in Hungary. I was the first person born in America, so I was kind of the golden child, and also the one that whose job it was to take care of parents, take care of grandparents, even if not financially or anything like that, but just providing hope that life could be different, that life could be better, that you could rise from trauma and have a beautiful life. So I sort of felt like I wanted, that was sort of what I did in my family of origin, and it just felt natural for me to do that for my career too.
And what's the practice that you do now?
Yeah, so I'm a clinical psychologist and I've kind of run the gamut of my first job, my first postdoc was at Northwestern, and it happened to be in the eating disorder program. And really, I didn't have a particular interest in eating disorders. I was interested in women's health. And I had done my dissertation on child sexual abuse as a precursor to prostitution. So I was working with a lot of women who were traumatized. And most of the women in jail, as you can imagine, are not criminals. They're really addicts, and they're supporting their drug habit with prostitution or retail theft. So that's why they were in jail. So, many of them were victims of abuse themselves and trauma.
And then how did you make the transition to eating disorders then?
Yeah. Well, there was a job opening, and I really liked the professor who headed the program. And she was someone who I had seen kind of in action, and I thought I would learn a lot from her. And it was a lot of women. Also, I was working in the obesity program as opposed to anorexia and bulimia. And my mom had struggled with her weight her whole life and had been on like a million diets. And I just had been around a lot of people who had dieting kind of issues, not anorexia and bulimia, but kind of the other end. So it was really interesting to me to work with patients who were compulsive overeaters and who were struggling. And really, they had a lot of unresolved trauma that was contributing to why they ended up being 300 pounds or 250 pounds or 500 pounds. So there was a lot of trauma work that I was doing at the time. So
And when you
once I started working in eating disorders, I really liked it because it's a symptom, but it's not the problem. And what you end up doing is saying, okay, why do you have these Hey, yeah, I think you're on mute. Okay. Wait, I still can't hear you. You're still on mute, I think.
I lost you, and this
You're
is what
not
happened
here.
with technology. I guess one of our connections went
I
down.
know, this is classic Zoom, right?
So
So,
I guess we'll
yeah.
reset. So now that you went into eating disorders, back then,
Mhm.
I guess, like you said, people didn't want to go to therapy or go to counseling.
Mhm.
When you
Right.
first started, was it more men going into counseling, or you saw more women, or maybe a
Definitely
little bit of
more,
both at the same
definitely
time?
more. You mean as therapists?
As therapists, I guess, would you see more of women come in and men?
Definitely
'Cause there was,
women.
like you
Yeah.
said, there was a big stigma. So
Yeah.
I would
Hmm.
imagine more men would come in as opposed to women. And then as I guess we advance as a society and it was acceptable, I guess you started to treat
Yeah.
more women now. Is that the
No,
case?
actually, women came in a lot more than men, believe it or not. Yeah. So because women are, more the emotional caretakers or whatever. Um, and then probably throughout my whole career, probably 85% or 90% of my patients are women, and only maybe 10 or 15 are men. But some of that is because of the field I'm in, because obviously when we are working a lot with anorexia and bulimia, and it's all about weight and shape. There's just that it's just a symptom women tend to pick whatever, have more than men do. But on the obesity side, we saw a fair number of men, so yeah.
So with your practice, do you specialize with the bulimia and anorexia,
Yeah.
or you work with all eating disorders?
All eating disorders. So anorexia, bulimia, binge eating, and yeah, those are the main ones. And then anxiety and depression. Um, I didn't do a lot of family work until later in my career. I would say starting maybe in my 40s. But now I really, really enjoy doing family work. And also, the older I've gotten, the younger the patients I work with are. So I work with a lot of adolescents and kids, 8 and up. So yeah, I was always an adult, like late adolescent and adult therapist, and now I'll go pretty comfortably down to like 8 or 10. So
And how many patients would you say you see per year now? I guess now you're more
yeah,
towards retirement, but like in your height of
right,
your career, how many patients were you seeing in an
yeah.
average year, you would think?
Yeah, so I was probably pretty unusual in terms of what I thought was a full workload. So I would say for the average therapist, it's probably 25 or 30 patients that they see um, a week, and some as many as 35, but I probably averaged closer to 50.
Wow.
So yeah, so I always had a really busy practice, and kind of how I did it was I would do like 12 a day. So I was able to really have a very nice work-life balance, even though I saw so many patients. But mostly I did that because I don't know. My husband and I both saw a lot of people, and we kind of had the emotional capacity too.
And
So
how long was each session? 30 minutes, 45 minutes, an hour,
yeah,
or
45 to 50 minutes. Yeah. So, yeah, so I've always kept my sessions around 45, 50. Some people, kind of didn't stick to that and would go to 60. And I really did, I lined mine up. So I stopped on time and, um, kind of held that boundary. And then that actually helped me to be able to see a few more people a day.
was there a certain routine you did every time with the patient, or depending what the patient was? Did you have to
Yeah.
do different exercises with them, or did you always try to do
Yeah.
the same routine depending
Yeah,
on the
that's
patient?
interesting. No, I think it's different with each patient, but when I was trained psychodynamically, which is more, like the Freudian kind of not traditional psychoanalysis, but kind of coming out of that frame where there's an unconscious, and the purpose of therapy is kind of to make the unconscious conscious. So you try to kind of do the deeper work of understanding what's really going on for people on a very deep level. And now therapies do so much more like skills work. Like we have dialectical behavior therapy and cognitive behavioral therapy. And at the time, it was more there was cognitive behavioral therapy, but it was more kind of short term. And then, what I was trained in is the deeper therapy. And that's frankly still what I like to do and still what I believe in, although it's not as popular today anymore. We've got a lot more skills kind of based, what they call evidence based treatment. And psychodynamic psychotherapy is really hard to do a randomized controlled trial and kind of prove that it works, because it's just it's got, kind of a deeper, almost spiritual component to it. It's very hard to kind of measure um, how people do. But the studies that have been done, it's, obviously an extremely effective therapy. But
Do you think there's one therapy that works better than the others, or again, it depends on what the patient and how they are in their life?
yeah, I mean, I guess, because of the way of my training, I mean, I do believe that doing the deeper work and doing the psychodynamic psychotherapy is really, really important. But I do a lot of behavioral work for people because it takes a really long time to kind of understand, for me, that the Holocaust had, that there was intergenerational transmission of trauma. And, it takes a long time to figure that stuff out. And if people feel bad, you have to help them in the moment too. So, and obviously, I'm working with people who have really life-threatening conditions too. So I do a lot of motivational interviewing, a lot of um, work on what are people's values, why do they want to recover, what are they working towards. Today was a really good example. I saw a patient who's really in the midst of a pretty raging eating disorder. I saw her about 15 years ago, 20 years ago. She recovered. She now is at midlife and relapsed. And I started seeing her again. And we had a great conversation. I thought she's a nurse and how she wants to go back and become a nurse practitioner and all about the meaning in her life and how there's this whole other side of her besides being a mom. And we had a really deep conversation. And I said, but you have to gain weight. You have to gain weight to be able to have those things in your life. And the whole 50 minutes at the end, she said, really, the only thing I heard about this entire session is that you said I had to gain weight. So, so she just, she wasn't ready to kind of integrate all the other really profound and important stuff we were talking about. So she's just, her head is really clouded by just the thoughts about wanting to lose weight.
Yeah, so some patients, I guess, are worse than others.
Yeah,
Some
for
maybe
sure.
just need therapy once a week. Do you have like an emergency number in case somebody's real bad and needs to be talked to at
Yeah.
that particular moment?
Yeah. Yep. And just in the history of my career, I've done everything from outpatient, some people just really need to touch base once a month, or I have people, who I saw at one time and they're, every few years they'll call me and say, oh, my mother-in-law is driving me crazy. Can I have a session with you? Or I'm in crisis about this one thing. Someone called me recently, her daughter, um, she found her daughter was being touched by an 8-year-old. Her daughter's 5, and she was freaking out and didn't know what to do and knew she could call me. So there's those kinds of patients. I would say the average patient I see once a week, for probably, a year and a half, something like that. But I also work with higher levels of care. So I've done everything from individual therapy to intensive outpatient, which is 9 hours a week, to partial hospitalization, 5 days, 7 days, 11 hours a day. And then I've done residential and inpatient. So I've really worked at pretty much every level of care in the field of anorexia, bulimia, and also mood and anxiety. So, so I tend to get sicker patients that need to be seen multiple times a week. And some people like to work with the, they call it the mostly the working well kind of patients. And some people like to work with the sickest of the sick. And I guess most of my career, I've worked with people who are really struggling a lot, you know. Now it's a little different because I only see about 10 people a week and I'm not as available because I'm partially retired. So I don't want to take on the commitment of somebody who needs to be seen that often and can't handle me going on vacation or whatever. So
So after, so usually you say you see a patient for about a year and a half, right? That
yeah,
when in
I
your
would
prime.
say, yeah.
After you're done with that patient, do you develop a rapport or you never really talk to them? I guess
That's a
every
good
patient's
question.
different. And if they
Yeah.
do build a rapport with you, are you able to go
Mhm.
out to lunch with them or dinner, or is that,
Yeah.
that's more getting into the
Yeah.
code of ethics? Like, take me
Right.
about, I
Mhm.
guess, a situation of somebody had a good relationship with you after a year and a half,
Yeah.
and then maybe want to get dinner to thank you. Like, what would
Right.
you do to,
Mhm.
as a code of ethics to
Right.
show that you have to stay professional?
Right. So, there's some question about it's supposed to be at least 2 years before you have any kind of different kind of relationship with a patient. In my view, it should be forever because I think that the therapy relationship is sacred and it's kind of you're always there for them and you never know when the person is going to need you again at a different point in their life, if they lose a parent, if they something happens in their life. So I feel like they can have a million friends. They don't need me as a friend. They need to preserve the relationship and the feeling that somebody's there for them whenever they need it. Of course, there have been weird situations. I had someone who called me who wanted to come in for therapy. She came in for therapy, and this was in Chicago, and we realized we grew up together in New Jersey. So I hadn't seen her since I was about 12 years old. But so at that point, we just had a really nice. I can't, be your therapist, but I'll refer you to someone. But I'd love to, get together as a friend with you every once in a while. So weird things like that, do happen. Or a former patient will be, somebody's a parent of someone my kid goes to school with, or, there's, especially as you get older and you've been in this field for as long as I have, there are little boundary things that you kind of always have to manage that come up. And then it's really good just to seek consultation from someone, another therapist or someone you trust or a former supervisor and kind of go, what do I do about this one? This one's really complicated. So.
And are
Mhm.
you, I guess are you familiar with the ACA code of ethics, or do you guys use a different code of ethics?
Yeah, we use the American Psychological Association Code of Ethics. Yes, I'm not really familiar with the ACA. Mhm.
So the ACA, I guess, is the American Counseling Association. That's what our
Mhm.
class focuses on, but again, there's
Yeah.
two other
Mhm.
ones. I think this one just breaks it down a little more because it has 9 sections.
Mhm.
Talks about examples. So like what you said about self-referrals,
Right.
it was good that you're able to
Right.
refer to somebody else. Like one of the code of
Mhm.
ethics, it says if you violate, like trying to have you as a therapist, even though they're your friend. So
Right.
that's a big
Right.
code of ethics. I guess
Exactly.
my main question is the big
Mhm.
one is about confidentiality.
Yeah.
So if
Yeah.
a patient comes in
Mhm.
and their wife wants to know what's going on, say the man comes in, his wife is in the waiting room, wants to know what's going on.
Right.
What would be what are you able to do so you could calm the wife down if she's not able to get the information and the husband doesn't
Yeah.
want to share? So how do you keep the
Right.
information private so it's just for
Right.
that person and not for anybody else to know about? Because
Right.
when you're
Well,
married, you want to know each other's lives, but some things
yeah,
they want to stay
they're
personal.
private. Yep. So certainly, automatically coming into therapy, it is confidential. So, we have the health insurance portability, HIPAA, and everything that a patient tells you is confidential. And even when we do Zoom, we use, a platform that is HIPAA compliant, and we use an electronic medical record that is also HIPAA compliant. So anything anybody tells you is completely confidential. There are many times when people will sign a release of information. So, for example, when I work with adolescents, I need them to sign an emergency contact and sometimes a release of information. And it can be that they're gonna it's just carte blanche. You can tell them anything, or they might say you can talk to them about anything related to my eating, but not related to my sexuality. I haven't told them I'm gay or whatever, so you can say certain things that you
So if
can't
they sign
share.
I guess, a
Yeah.
condensed
So if they
form,
sign a release of
a form of
information,
release, you're allowed to
yeah,
share the information.
you're allowed to share the information. But therapeutically, you're always thinking like, why, what do they need to know and why? And for in this example, what I would want to do if, with a man like this who maybe he's like, no, I don't want to sign a release for my wife, but it's okay if she comes in for the last 15 minutes. And if she's in the room, then, I can work with him on what it's okay to say. And usually I would try to encourage him to tell her as opposed to me telling her, but I might nudge a little like, oh, well, you are drinking every single day
Right.
and blacking out, and it's probably something your wife should know, so I'd work with the person over time to share the important stuff so that their partner can help them, you know.
Yeah, that's a big thing. When you're in a relationship, it's all about having connection and feeling comfortable with each other,
Yeah.
for
And you
sure.
also asked me earlier, which I didn't answer, which is how do people contact me? And, some people are different and they keep their boundaries really, really tight. I actually do give my patients my cell phone number, and my cell phone is my business number too. So, for me, it just was easier not to carry, seven
Two phone?
phones or whatever. And obviously, if I don't recognize the number or if it's a patient, I don't pick it up when I'm with my family or I don't have privacy or something. But I do let people text me. I am available between sessions for emergencies. And to be honest, I really don't have patients that abuse it. Um, but again, I work with people who I want them, I get a text from someone on a Saturday night. I'm sitting here by myself and I feel like purging, and then I'll text back, don't do it,
Yeah.
and so, and I've gotten a lot of training in dialectical behavior therapy, and you do kind of coaching, and you are available. So that's a choice. My business partner right now, she never gives patients her cell phone number. She has two different numbers, her personal one and the one that patients can call on. Some people don't give their email, other people do. I'm pretty accessible, but I can honestly say I haven't had people abuse it. And
So it
if
depends
there
like what
were,
person you are.
yeah,
So there's no rule of conduct that says you can't give out your phone number, you can't
no,
give out your
mm-mm,
email.
no, mm-mm. But you have to be careful always.
Absolutely.
This is
Because
not for you. Like this relationship, no matter how much you love your patients, because I think you do love your patients in many ways as you get to know them and help them over time. similar to how a parent might love a child, you know? So we don't have as many patients, say, as a, a physician. So if I'm working with 30, 40 people and I'm working with, someone who I've worked with for 5 years or whatever, like, I feel like I care about them deeply. I don't know if that's you love them as a caretaker might, but it's not about my feelings about them at all. It's 100% about what they need from me, and I shouldn't need anything from them. And that doesn't mean your work isn't gratifying, but that is not what it's about. Their job is not to gratify me in any way, shape, or form. So,
No, absolutely. And I was going to ask, now that we have Zoom and technology,
mhm.
do you do any telehealth
Yeah,
calls now? And
yeah.
if you do, how
Mhm.
do you allow a patient, if they don't have a lot of privacy, to maintain a confidentiality, again, with you and without their family knowing, if they don't have a lot of privacy using the telehealth? So how would you
Yeah,
go about that process? Would you recommend
yeah.
them coming in person instead, or would you try to do a session and not really talk about anything deep in details? What would be your
Hmm.
process about that, or your thought
Yeah.
process?
Yeah, and in my private practice since COVID, I have been probably 95% virtual. I have a small home office, and that's also a little different too. My husband and I have always had a home office, and we didn't let everyone come to our home office, but patients that we knew and trusted, we did, have a series of patients we saw at home. But since COVID, I have done all telehealth except for at the treatment center that I work at from time to time, and that was all in person. But I actually like telehealth better because at the treatment center we were wearing masks, and it was kind of,
Are
you
to
know,
talk
yeah,
here the whole.
yeah, it's like six one way, half dozen the other. But I think with higher functioning patients, you can make a really strong connection virtual. In fact, I was talking to someone today because I am going to go back to the office a little bit downtown Chicago. And I was saying, oh, you can actually come in person if you want. And she's like, yeah, we've never met each other in person. And I've been working with her a year and a half, and it doesn't feel like I never met her. So it's been a pretty incredible transformation, I would say, with Zoom. I mean, there was just no telehealth before
Yeah,
COVID. It was
and
maybe you do a phone
I think
session, but
I would say you and
mhm,
other therapists probably love telehealth because it
yeah,
makes your job
yeah,
easier. One
yes,
thing we were discussing with telehealth is, say somebody that lives in a rural area and they have to
yeah,
commute 45 minutes. Now that allows
right,
them to save an hour and a half of
yes,
driving time, and then they can work
right.
from home and get other things done. So I
Right.
think,
And Jake, what I've noticed too is I don't have cancellations. People do not cancel, partly because they're working from home too. And
right,
and it used to be all evening. Everyone wanted evenings and weekends because they work during the day. And as a therapist, you only have so many slots on the weekends and evenings because you want to have a life too. And now people can come during the day, they can get a lunch hour and break away. So just access to care is so much better. And the privacy thing that you asked before, like I've had people go in their car, it's like, okay, I'm in school, but I have a free period. Let's do my therapy session now. And they're sitting in their car, or if it's nice weather, they're sitting outside with their computer. As you know, young people are pretty good at, finding a place to do their technology. And
absolutely.
yeah,
About an
so
older patient that's not familiar with telehealth, would you
yeah.
walk them through the steps, or would you recommend them still trying to come in if they could?
I mean, I think, for someone who's really acute and really, really struggling, there's nothing like meeting in person. And I think all of us are kind of finding that when you go to a conference now and you're like, oh my God, it feels so good to be with people. And I think, for example, the patient I was talking about that relapsed, I really think I could have contained her much more in the room. Like there's just something that happens in the relationship that is stronger and more profound when you're meeting in person. And I'm glad. I mean, there is something to human connection that is a little tougher with the screen. And I think therapists are going to have to get out of their comfort zone and not just do what's convenient for them, but recognize that, they got to get back in the office too. So,
Yeah, so you're saying you like the telehealth, but it's hard to build that emotional connection with patients through Zoom?
yeah. So, yeah. I mean, you do, but again, if someone's really, really struggling, like if someone's anorexic, I can't see them. And I do need to know, it does help me to look at their body
Right.
because they don't, I mean, and I guess they could weigh themselves and they could show me themselves, but the screen is, it's just,
You don't know the
it's a
true
little
field of
different.
vision when you get the
Yeah.
screen. Like right now, my
Right.
screen, like I look a little red. I'm sure I'm not really that red in
Yeah.
person. So
Exactly.
you hard
Right. So I
hard to
can't,
get the full detail.
right. And if someone is like suicidal and I mean, I can't get them to tell me the stuff they need to tell me if they're struggling to tell me it, you know? Like it's hard to imagine somebody like really going, okay, I'm gonna open up and tell you I was sexually abused
Right.
or that, I'm gay or like some really big momentous thing. It's just hard to imagine doing it over Zoom, you know?
No, I love everything you're saying. I don't want to keep you too long, but I'm fascinated
Yeah.
by everything you're saying.
Yeah. Thanks, Jake. Yeah.
But your husband, you mentioned, I guess, is
Mhm.
also in the field of counseling, right?
Yeah. Yeah.
Going back to the confidentiality,
Mhm.
you guys are not supposed to discuss anything between your patients.
Well, as long as we maintain the patient's confidentiality, like I would never use names or
Okay,
anything
yeah.
like that. But with him or another psychologist, I might say, I have a client. This client is nothing that would identify who they are, but this person is binging, and purging 7 times a day. And I've tried A, B, and C. Can you think of something, another technique I should use? So some consultation you can do, but you would never.
So it's like similar to
Yeah.
HIPAA, like you could use
Right.
certain information as long as you don't give away the patient's name and
Yeah.
their private
Right.
information.
It's like a doctor going, you know what, they have colon cancer, God forbid, or whatever. And here's what I'm thinking of doing, but asking a really esteemed colleague, do you think this is the right thing, to do? So,
And last question.
mhm,
If a patient comes in, they got recommended therapy or maybe they wanted to try therapy, but they're not
mhm,
comfortable to opening up to you yet. Is there
mhm.
anything you do to make them feel comfortable so they'll start opening up to you?
Yeah. Yeah, and I mean that definitely happens with, let's say, teenagers a lot, like they're not gonna tell you what's going on with them. And especially if they've grown up in an environment where they've been shamed or no one talks about their feelings, it's gonna be really hard for them. And for some people, those are really, really hard patients to treat because as a therapist, like all you have is what people are telling you. So we don't have like, blood work or this or that. I mean, it's all about what someone's willing to share with you. But you have to go slowly and you have to um, you know, ask a lot of questions and try to draw the person out. And there are different things you can do. Like I like doing a value sort, for example, with people. So if you kind of go, what's important to you in life, and you give them a whole list of things that are important to them, that people usually like that, like, oh, these are some of my values. I like relationships and um, music, or, you ask them more about who they are and what their interests are. You can also use journal prompts where you kind of say, okay, I want you to do this journal prompt for homework and then bring it in, and then they can read what they wrote. So, yeah, so sometimes we have to work harder than the patients because they're working hard, but you don't just sit there and listen. I mean, you have to build rapport, and not everybody is comfortable talking.
Yeah, I could definitely relate. As you know, I do basketball.
Mhm.
I could relate
Yeah,
when I work with older guys and I try to ask them and they're not interested in talking to me. So the
yeah,
way I approach it is I ask them about a case play or a situation in a game that happened with me and see how
yeah,
they would take their approach. Is
yeah.
that something you do? I guess
Yeah,
that's
sure.
similar to
No,
what
you
you
can.
do.
Yeah. And I do think, I mean, you don't want to share too much about yourself, but you can, examples of things and ask people how they would cope with it and how they would deal with it. And, this is what you've seen from some other people, how do they respond to this? So, yeah. And I mean, with littler kids, you do play therapy, but sometimes you'll play checkers, with the kid for weeks, and then they'll just all of a sudden start talking about stuff. But I think even just trying to build that connection, even if someone isn't ready to open up, I still hope it's a healing thing that they can sense that you care about them and that at some point in their life they can open up, you know.
All right, that was great. I'm sorry, I got
Yeah.
one more question. One more question.
Okay.
I want to
Yeah.
learn about this.
Okay.
When people go to therapy,
Hmm.
sometimes do you think the therapist needs to have experience to relate to that patient, or you think you have enough information where you are able to relate to that patient without having that experience?
Yeah. It's interesting. I mean, I was really trained not to share much about my experience at all. And no, I don't think you really have to have been through what the patient has been through, because there is kind of a human experience, and everyone has experienced some suffering, some loss, some grief. I mean, they're human emotions. And I don't think anyone should be a therapist if they haven't been in therapy themselves. So hopefully they will have done some of their own self exploration. So there's not topics that they don't want their patients to go into, because it will stir up too much in themselves. So, and actually, when I was training, we had to go through psychoanalysis. So I was like on the couch being psychoanalyzed 4 days a week for 45 minutes for 6 years. So,
Well,
um,
have you ever had a patient that came in and said, was, I guess, purging, right? For example,
yeah,
that's
and
something
said,
as ourselves, we're not going to go and start purging, so we don't know what it's like. But do you
right.
think if you had their experience of, you say you grew up and you started purge and then you became a counselor, you think you would be able to relate better to them?
I
Or
don't
since you have
think
so much
so.
knowledge about it, you're able to
Yeah.
just
Yeah, I
help
don't
them
think
out?
so. Yeah, I don't think so. I mean, and we do have peer groups for people who have had similar experiences. And certainly with AA, the idea is, that your peers can be super helpful. But I think I could help somebody who's alcoholic, even though I haven't been alcoholic myself.
Okay, yeah.
Yeah. Hmm.
Because
So,
I think when I was in undergrad, the best example
hmm.
for exercise science, my
Hmm.
teacher said, how many people have ran a marathon? And maybe two people raised their hand. He
Yeah.
goes, how are you going to treat them and know what's wrong with them, what they're feeling if you never ran a
Yeah.
marathon? So he was
Yeah.
trying to go out and maybe you should get more experience, but I guess there's certain
Yeah.
situations where it doesn't make sense. I guess you learn from your
No.
experience working from other patients.
Right. And even though you didn't, maybe for you, a 10K would be the equivalent of a marathon for somebody else.
Right.
So I think having an experience that's like grueling the way a marathon might be, but it doesn't have to be the marathon. You know what I mean? So, and maybe it's not even physically grueling, maybe it's the mental grueling part. But
So you pretty
but
much say you just have to be relatable to them. You got to be able to
yeah,
relate. It's not, it's all
exactly.
about the
Exactly.
experience. You just got to relate a little bit. Oh,
Right.
that's awesome. All
Yeah.
right.
So,
I think
okay.
that's all the questions I have tonight. I really
Okay.
appreciate
Okay. Well, you're a
all your
great
time.
interviewer, Jake. So,
Ah,
and
I get
yeah,
it from my father,
I
I
know
guess,
this isn't
right?
your field, but you could be a really good therapist too. But I
I
think
guess, in
you've got
sports
a
psychology, we call it ORs,
yeah,
and it's a lot of open-ended questions that
yeah,
to get people
no,
talking. And I guess
right,
with me dealing with,
absolutely,
I would say, the public every day, I don't know what I'm going to
right,
get. So you just learn how to
right.
adapt to them.
No, absolutely. There's tons of psychology in sports, and and I think to be a good coach, to be a good ref, to be a good teacher of any kind.
I would be honest, if I had more time and I wasn't burned out from school, I
Yeah,
think I would, because right now my program's 86 credits, which isn't too
yeah,
bad. But if you
yeah.
want to go into counseling, it's
Mhm.
121 credits. I don't
Right.
think I have that mind and
No, and you're
mentality
already
anymore.
coaching it. I mean, if you weren't succeeding in what you're doing like Mark's like, I'm going to go to his first NCAA game. I mean, that's amazing.
Yeah, so
At
if I
your
wasn't
age,
doing
you're
all that
already,
and I wasn't burnt out from
yeah,
school, I think I would definitely love to go the counseling route because you really get to build
yeah,
a emotional connection with people.
yeah,
You get to learn
yeah.
about their
No,
stories and get to help them.
it's a great field. I mean, it's hard I don't want to retire because it's really meaningful work. So,
Is there
yeah,
is there a movie you recommend about counseling that you think is worth a watch?
I like Goodwill Hunting,
Okay,
actually.
yeah, I've seen that. Have you
Yeah,
ever seen Lars in real life?
no. Mm-mm, mm-mm.
So brief story. It's about a guy who his girlfriend's a sex doll, but I guess he
Mhm.
had so much trauma in his life that he thinks the
Yeah.
sex doll is real.
Oh,
So it's
wow.
definitely
Yeah.
a great movie to watch. I don't
Yeah.
know if you
What's
had
it
any other
called?
movies.
Lars?
I think Lars in real life. Let me.
in real life? Oh, wow, that sounds
Ryan
fascinating. Yeah.
Gosling's in it. Lars and
Oh, I like him a lot.
yeah, Lars
Yeah,
and the Real Girl.
yeah,
That's what it's called. Lars and the Real Girl, and the
in
Ryan
the real world.
Gosling is in it.
Mhm.
But I didn't know if
Yeah,
there was any other movies besides Good Will Hunting that you recommend.
yeah. Not
Yeah,
really, it's really interesting. There aren't, I mean, The Sopranos. There was
yeah.
a good therapist in there,
I
but
obviously from
oh
New Jersey.
boy.
I think we
Yeah.
know
Yeah,
about The
you've seen
Sopranos and
plenty of
watched
that,
it.
but I don't know. I mean, that's one I can't work with sociopaths. I mean,
Yeah.
I'm used to working with victims. It's a lot of, I know there's a lot of abusers that need help too, but that's hard for me. So,
All right, awesome. Well, I'll keep you posted.
okay.
Until
All
last
right.
minute
Let me
because
know
I
if
got
I
so
can
many
do
things going
anything
on.
else.
I think we
Yeah.
might have to do one or two more interviews, but next
Mhm.
interviews might have to be a little more about the ethics. But I think we covered a little bit.
Yeah.
But I'm like I
Okay.
said, I'm
All right.
fascinated what you have to say. I
Yeah.
could talk to
Okay.
you for
Thanks,
hours.
thanks, Jake. And if you need, yeah, and we can talk offline anytime. And if you need another therapist, like I have other people I can recommend
All
who
right,
would be happy
awesome.
to do it, or if you want to interview Glenn or whatever.
All
So,
right, yeah, I'll definitely take your word on that. So I
okay.
appreciate it, and I guess I'll talk to you
Okay.
soon.
Yeah, I'll see you soon.
All right, thanks
Okay.
for your
Take it
time.
easy. Okay. Bye.